Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert on molecular pathology. But before doing so, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. While molecular pathology provides a comprehensive understanding of disease at its fundamental level and combines molecular analysis with traditional morphological and immunohistochemical methods, the field is continuously evolving as new information becomes accepted into mainstream. With molecular pathology, our understanding of the genetic mutations that lead to disease and our choices of advanced therapies has been greatly expanded. It's uncommon now to see a tumour specimen from any organ reported by pathologists without reference to the genetic mutations that have been previously documented and we know may be present. And noting this rapidly expanding field of medicine, I was curious to delve further into the world of molecular pathology, a science often conducted a little remotely from the coalface of clinical medicine, yet dovetailing critically into the establishment of treatment algorithms and prognostic modelling. Essentially, I was interested in reviewing some of the basic science at play. Well, the 10 hallmarks of cancer include genome instability and mutation, resistance to cell death, the ability to sustain proliferative signalling, evading growth suppressors, enabling replicative immortality, inducing angiogenesis, activating invasion and metastasis, reprogramming energy metabolism, tumour-promoting inflammation, and the ability to evade immune destruction. Well, the precise scientific detail explaining how cells escape normal, healthy biologic programming and develop the chemistry that allows these cancer hallmarks to develop is beyond the brief of this podcast. However, it is important to remember that intracellular signalling and cell proliferation has some very important players, and we can briefly review these. Well, within the DNA housed in a cell's nucleus, there are genes that both promote normal cell growth and a group of genes that function to check or control normal cellular growth. These genes are called proto-oncogenes and tumour suppressor genes, respectively. They function in normal healthy cells in a beautiful dancing balance, with the tumour suppressor genes applying the brakes, the checks, and the balances required to prevent excessive cell proliferation. Well, unfortunately, gene mutations of either proto-oncogenes or of tumour suppressor genes disturb the perfectly held balance of cell metabolism, growth and function and may steer the cell with a now altered DNA blueprint toward unregulated proliferation. Mutations arising through inheritance are referred to as germline mutations, and these are present in every cell of the affected patient. The term somatic mutation refers to an acquired error possibly triggered by epigenetic factors driven by our environment and lifestyle, such as cigarette consumption, ultraviolet light exposure, and a variety of dietary choices. When such mutations affect a proto-oncogene, it's subsequently referred to as an oncogene, and we will briefly consider RAS and BRAF oncogenes, which come up repeatedly in molecular pathology. Well, in the thumbnail sketch, RAS is involved in so-called upstream chemical signalling and is switched on by incoming signals, ligands, from the external cellular environment. Once activated, RAS activates, in turn, an intracellular cascade of chemistry which ultimately turns on genes involved in cell growth, differentiation, and survival. If RAS genes mutate and become oncogenic, this may lead to the production of permanently activated RAS proteins, inducing overactive signalling within cells. The 3 RAS genes in humans, HRAS, KRAS, and NRAS, are the most common oncogenes in human cancer, and mutations that permanently activate RAS are found in 20 to 25% of all human tumours and specifically 90% of pancreatic cancers. Well, whilst RAS genes are found on chromosomes 11, 6, 12 and 1, the BRAF gene, coding BRAF protein, is located on chromosome 7 and is involved in so-called downstream signalling, playing an equally crucial role in regulating cell growth, differentiation and movement, with mutations altering the activity of various transcription factors abnormally affecting gene expression and cell growth. BRAF mutations are found in 10% of colorectal cancers, up to 50% of papillary thyroid cancer, and 26 to 67% of melanomas. We may have seen other oncogenes in reports such as the MYC that encodes a transcription factor, EGFR, which stands for the epidermal growth factor receptor, involved in cell growth and survival, and HER2, human epidermal growth factor receptor 2, a protein that regulates cell growth and division. Amplification of HER2 is a hallmark of some breast and ovarian cancers. Well, there are many described. This knowledge is significant as several oncological treatments involving JAK molecules, all of which end in the suffix nib, and monoclonal antibodies target these abnormal protein pathways or cell receptors that otherwise promote them. A single mutation is all that is required to activate an oncogene. Conversely, the tumour suppressor genes are involved in a variety of functions, including repairing misaligned tiny segments of DNA where opposite strands become mismatched, as in Lynch syndrome gene mutations, cell cycle control, apoptosis, promotion or telomerase regulation. A mismatch becomes more common with ageing as telomeres shorten, and the repair is referred to as mismatch repair. A mutated mismatch repaired tumour suppressor gene is no longer able to carry out this function, and abnormal protein synthesis and maladaptive cellular processes result. Well, as we will learn in this podcast, these gene abnormalities can be detected in tissue specimens after molecular pathologists apply analytical methods including immunohistochemistry staining. The term mismatch repair proficient, where the normal genes are detected and a mutation therefore is not present, and mismatch repair deficient, where a gene mutation is present, will often be seen in reports accompanying tumour diagnosis, especially in relation to colon cancer. The BRCA genes, BRCA1 and 2, and Lynch genes, MLH1, MSH2, MSH6, and PMS2, are well-known tumour suppressor genes that, when mutated, dramatically increase the risk of developing breast, ovarian, and prostate cancer, and both colon, uterine, urogenital, pancreatic, and many other neoplasms in the case of Lynch. Whilst these mutations are generally recognised as being inherited, they may also arise spontaneously or through epigenetic silencing. As there are two copies of these genes, and only one is generally inherited in family cancer syndromes, a somatic mutation of the other copy in a single cell or small number of cells must take place before the tumour suppressor activity is removed. This is the so-called two-hit hypothesis proposed in 1971 by Knudsen and accounts for tumour development as we become older. Interestingly, inheritance is associated with a higher rate of somatic mutation in the second gene copy. Another term, methylation, is sometimes also included in pathology reports. Methylation of particular amino acids within a gene, specifically cytosine to adenine, CGA, possibly driven by epigenetic factors, leads to dysfunction of DNA repair processes where mismatch arises and failed tumour suppression function is the consequence. Certainly there's a lot to take in here. The science is fascinating. As noted, this was a simplified overview of a fascinating and complex branch of science. But to discuss this further, I'd now like to introduce Dr. Pranav Dorwal, a molecular and anatomical pathologist who works in the departments of diagnostic genomics and anatomical pathology at Monash Health. Dr. Dorwal is an examiner for molecular pathology, is an active researcher, and has more than 60 publications to his credit. He's worked in the molecular pathology services at MD Anderson Cancer Center, Houston, and Memorial Sloan Kettering Cancer Centre in New York. Pranav undertook a visiting fellowship at Australian National University, Canberra, and was awarded the Chancellor's Gold Medal during his diploma in clinical pathology. Now, please welcome Pranav to the podcast. Pranav Dorwal, it's a great honour for me to have you here on Everyday Medicine. Thank you very much. Molecular and anatomical pathologist, and a lot of responsibility on you, Pranav, reporting all the specimens that come across your desk. We really are appreciating this conversation because there's so much genetics now that is coming forth to us as clinicians, and whenever pathology is reported, there seems to be a genetic report associated with the basic histopathology. So I really want to try and dig deep and understand the reports that we're seeing across our desks when surgeons remove tumours and so forth. So that's really where we're headed today, discussing the science and your how we should interpret the histopathology. But before doing so, Pranav, thank you. I wonder if I could ask you, sir, describe what you do and your journey. Take us there.
Okay. Yeah. Thank you so much, Dr. Cantrock, for having me on your show. And So let's start with my day, like a routine day, because as you said, I work across both histopathology, which if you go to different places, some places it's called anatomical pathology, some places they'll call it histopathology, in other places they'll call it surgical pathology, which all mean the same. So I spent part of a few days in histopathology and others time in genomics, which dealing with the solid tumor genetics. So my days will depend on which part of the hospital I'm in. So when I'm in anatomical pathology, then we walk in to the lab and you get your allocated number of cases for the day and you go through them. Some you're able to report just based on the routine slides, which in pathology parlance we call them H&E, which stands for hematoxylin and eosin. Some cases would require additional testing, which we call them special stains or immunohistochemical stains, which I'm sure we're going to discuss about those later in the talk as well. If we talk about more a day in genomics, there it's analyzing the genomic data. So a tumor, when we sequence it, so you're trying to read the genomic sequence on a tumor and then trying to find the variants that are there. And they may have different implications for the patients. It could have diagnostic implications where those genomic changes are helping us reach a diagnosis. Could have therapeutic implications where if you find a particular target, then that can be used for treatment for a patient, or it could have prognostic implications. Again, that might determine the management of the patient. So some mutations or genetic variations being present are a poor prognostic marker, where other could indicate a good prognosis.
Sort of leads to precision medicine. Why did you choose pathology? Take us back to your choice here.
Okay, so I chose pathology. I was interested in pathology right from my med school days. So in year 2 of med school, we used to learn pathology. And that's where I was interested in because it was always excited me. It's kind of a detective work. When you're putting a slide under the microscope, you don't know what you're going to find. A lot of the times, the clinical history is provided, clinical differential diagnosis or a clinical suspicion is provided to us, and things match. But the interesting part is when things don't marry along very well, and then you find interesting findings. So I'm sure you must have come across the reports in your practice as gastroenterologist where you find incidental tumors or incidental findings, appendix being taken out for an appendicitis but comes back with an endometriosis, or there's a bug in there.
Yes.
And so those kind of things, and sometimes you are in kind of a hunting. There are tumors which you don't know what they are, and sometimes there's surprising diagnosis. So that is what always excited me, and that's why I chose pathology as a career.
Well, thank you for taking us back to those decisions. Yeah, it is fascinating, and I don't think we have perhaps enough exposure as medical students. At least that's been my feeling. I've always enjoyed looking down the microscope and thinking about what the cells are like and the structure and then the function. Thank you for that.
And just to interject there, because as you rightly said, there's not enough exposure for pathology during med school. So keeping that in mind, so the last couple of years I've been teaching the students at Monash University, the medical students, where we show them real life cases and how we approach a case and get to a diagnosis, so they get a taste for it and a feel for real life pathology, because a lot of time it can be a bit mundane, a bit theoretical pathology. So I think it's important as medical students for them to understand what real life pathology is like.
Yes, you sort of understand the disease process much better. We do get a little estranged from it, I think, once we enter clinical practice, because we get focused on seeing patients, talking, running off diagnostic tests, and I think in the big hospital like Monash, you do have various meetings where pathology is reviewed and so forth. I think it's really interesting for us to be able to engage with that. Just to take us back to the science, where we start thinking about about malignancies. I just wanted to review the science with you. We've got in a normal cell proto-oncogenes, and we have tumour suppressor genes, and these two, like accelerators, the proto-oncogene, tumour suppressor gene, the brakes in the cell, critical for cell function, cell division. And then sometimes things go awry. Mutations occur in the proto-oncogene and they become an oncogene. There's a gain of function. And then the tumour suppressor gene, either as an inherited or as an acquired somatic defect, mutates and its function gets blocked. So we've got an abnormality in the tumour suppressor gene. gene, and these tend to lead to alteration in function and proliferation of cells. Can you just run through this with us? Tell us a little bit about proto-oncogenes. We often see the term RAS and BRAF coming up. Are you able to just expand on my very naive kind of comments there about these different...
Sure. No, absolutely. And what you've said is exactly, you kind of answered your question in there as well. So in the very simple terms, as you rightly said, so proto-oncogenes are kind of the normal counterparts of oncogenes. So proto-oncogenes, as you said, they're like accelerators. So I think it's one of the best analogies that you can give is when you're driving a car, your proto-oncogenes are like your accelerator and your tumor suppressor genes are like brakes in a cell cycle. So proto-oncogenes are normally present and they're normally active, but they work in a very controlled manner. But when they have some variants, they're abnormal or pathogenic, as we say, and then you call them mutations. So when you have mutations, then they become hyperactive, and then they're called as oncogenes. So a variation where an oncogene is hyperactive, that will lead to increased cell proliferation. On the other hand, the tumor suppressor genes, they function in a way where they kind of, again, they work as brakes in a cell cycle. So if you're driving a car and your brake malfunctions, then it goes out of control. So similarly, if there's a defect or a mutation in a tumor suppressor gene, or their function is hindered by any other epigenetic mechanism, then they can impact the cell proliferation. So, where the cells were not supposed to divide, they're dividing, and that will lead to tumorigenesis. So that's in a nutshell. So like, for example, as you said, KRAS and BRAF, these are your oncogenes, and some of the tumor suppressor genes are like P53 and RB1. So those are kind of your tumor suppressor genes. So yeah.
There are a lot of these, aren't there? But, just thinking about the oncogenes, the RAS and the BRAF, and the RAS, I think, is the upstream signal, and the BRAF is a little bit downstream. But those proteins are all linked in terms of how they are eventually transcribed and the effects that they have on cell proliferation. But do we understand why a mutation occurs? Is it purely epigenetic factors? We understand cigarette smoking and ultraviolet light and various dietary factors have an impact. Do we understand, beyond saying, well, these are known to influence it, irradiation and so forth? Do you have an understanding of why do we get these various mutations?
Yeah, so these are basically biochemical changes. So as you said, that UV radiations can cause mutations, as we see in melanoma cases, and we call them mutational signatures. So you have these C to T transitions that you see in melanomas, and in the case of sometimes they can be very, very poorly differentiated. So we use those signatures to make a diagnosis in cases. And another example, as you said, in cases of lung cancers, you have these smoking signatures where you have deamination of these nucleotides. And body in general has a mechanism. So all of us, even if we have cancer, we don't have cancer, we all have this lot of repair mechanisms which are always active. Okay, so there are changes occurring in our DNA, but they're being repaired on an ongoing basis. But when the mechanism fails, then those changes are not being repaired, and ultimately they lead to cancer formation.
If we think about the tumor suppressor genes, my understanding is that these are often inherited. Abnormalities are often inherited, but they can also be just random events, somatic events, just like we've discussed with the oncogenes. Is that right? Yeah. And can you explain the term mismatch repair in a little bit more detail to us? So this is something that the tumor suppressor genes are involved in, as I understand. Can you explain that term to us when we talk about mismatch? Yeah. What are we talking about?
Sure. So as I said, so we have all these events in our DNA where when a cell divides, the DNA replicates. It's not a perfect mechanism. Sometimes when the DNA replicates, there will be errors which will come into that replication. So the nucleotides don't match to each other as they should. So in those cases, the body will have, as I said, there's a mismatch repair mechanism which will correct those changes. So suppose So when that mechanism is malfunctioning or not working properly, then those variations are not corrected, and then that is called as a mismatch repair deficiency. Again, as I said, they can be inherited or they can be acquired. So in inherited syndromes, for example, Lynch syndrome, which is one of the best examples in case of colorectal cancers, that can happen. You have mismatch repair deficiency, but that's an inherited syndrome. But you can also have sporadic, where it's an acquired defect.
Yes.
But again, that has the same pathway.
It's very complicated, isn't it? So when we talk about microsatellite instability, are we talking about areas, segments of DNA that are not perfectly represented because there has been a mismatch repair, a problem with the repair? Is that what we're referring to? Yeah, so a consequence of mismatch repair is we get microsatellite instability, bits of the DNA that aren't represented as they should be, and this leads to incorrect protein development and incorrect messaging, etc., which can lead to proliferation. There's another term that I'd like to ask you about, which seems to come up a lot in relation to bowel cancers in particular, and that's the concept of methylation. So just tell us about methylation that occurs, because this seems to often turn off tumour suppressor genes as well. What are we talking about when we talk about hypermethylation? Just explain that term to us. How does it arise?
So as you said, methylation is an epigenetic mechanism. So because the genes are under the control of these promoters, which if they are methylated, then they'll kind of suppress the activity of a particular gene.
Yes.
Okay. And that is another pathway where you can have mismatch repair deficiency, but that is usually not an inherited pathway. That's usually seen in the sporadic cancers. So for example, there's a mismatch repair deficiency, which is not inherited. Then in those cases, for example, the best example is again MLH1 promoter hypermethylation. So it's abnormally suppressed. That gene is abnormally suppressed, and that leads to mismatch repair deficiency.
And the idea that the methylation, when you mention epigenetic changes, again, my understanding of this is that we're talking really about the environment of the cell. Is that right? That's having some influence. The external environment is talking, if you like, whatever the chemistry is in the external environment, the internal environment through receptors. And that epigenetic concept, when we're talking about that, we're talking about maybe an influence from cigarette smoking, for example. It could be that, or some dietary protein, or we're talking about that influencing it.
Yeah, so absolutely. So environmental factors are one of the epigenetic mechanisms. But in case of like the promoter methylation, those are not part of the genes, but they're part of the promoter region of the DNA. So they're still in the DNA, but not definitely part of that particular transcribing gene. And similarly, you can have changes in the histone proteins around which the DNA is coiled. So histone acetylation and deacetylation can also influence the function of a gene.
I see. So there's a whole lot of chemistry going on in the cell, which normally is held in a beautiful balance. But then we can either have inherited tendencies that affect that balance, a chain of events can occur, or we have epigenetic factors that can affect that balance, which might lead to mutations. It might lead to, as you said, these promoter regions being influenced. So you get methylation, which then affects the way the gene is transcribed. So it's complicated, isn't it? We've got the tumour suppressor genes, P53. There's a bit of a book I read about P53 being this. When it was discovered, people weren't quite sure, and then they realised this was like the orchestra. Is that right? The guardian of the genome. Guardian of the genome. Yeah. But if we think about other things that discussed a lot, genes like the BRCA1 and BRCA2, they're tumour suppressor genes. The Lynch genes, and there's MLH1, MSH2, MSH6, PMS2, and then I think there's EpCAM, which affects MSH2. There's quite a few genes all packaged up in there. That's a common problem. APC gene, which is discussed in regard to familial adenomatous polyposis syndrome. Lots of these genes they're all suppressor genes that can go awry. Now, here's one other question for you. They can be inherited, by which we mean they're germline and they're in reproductive cells, or they can be somatic and acquired. But when we think of the tumour suppressor genes, we have two alleles. So we inherit an abnormal gene on one of the alleles, but we have a nice healthy allele. So this leads to this so-called two-hit hypothesis that Knudsen came up with, that you need to lose the other gene, am I right, before you get this abnormality being expressed, because there's still a control from the good allele.
That's right. Yeah, that's right.
And that's why it takes a little bit of time. The tumour's not going to develop when you're 6 months old. It's going to take years before there's enough events to occur. Oh, now we have a mutation. Now we're in full swing. We're in cancer mode.
Absolutely. And as I said, and usually in most of the cancers, it's a multi-step process.
Yes.
But the patients who have an inherited abnormal allele in a particular gene, and that's why they have a tendency to develop these cancers. And that's why we see when the patients who have Lynch syndrome, they present with these cancers early in their lifetime.
Yes.
Compared to the sporadic ones which occur later. So when you have a patient who might be in the 30s or 40s and they have this cancer, the suspicion is always higher that they might have some kind of a inherited syndrome.
Yes. Okay. So we have this two-hit hypothesis. You need both things for tumour suppressor, but not for the oncogene because it's a gain of function. Can you explain, if you have a loss of the tumour suppressor genes, do you still need mutations of the proto-oncogenes? Do you still need oncogenes present?
Not in all the cases, but you have these cases. So as you said, you have this multi-step process. For example, in the typical colorectal cancer patient, the early event, and we see that all the time in these colorectal cases when we sequence, most of them have a mutation in the APC gene.
Yes.
But in the due course of time, they acquire other mutations. For example, in a proto-oncogene, which is RAS, so they acquire KRAS mutations where they transform into a dysplastic polyp, and further downstream they acquire other mutations. For example, mutations in P53 or other genes like ARID1A, and then they transform into an invasive cancer.
Yes.
So it's a multi-step process.
Multi-step process and a big chain of events. Well, look, thank you for running through that. I think it's that background science is really interesting and it's incredibly complex. I don't understand actually how people have worked this out, given that they're not able to look into themselves. Somehow people have worked this out. I'm always fascinated by this. It's like theoretical physics as far as I'm concerned.
We're all learning, isn't it? Like it's an ongoing process, and with new publications and research, we're learning every day. Newer and newer.
Yes, and people work out how to suppress things. As you mentioned before, it's important to know this because we can use JAK inhibitors to turn off some of these BRAF mutations and whatever. Somehow scientists have worked out, well, yes, we know there's a mutation, and now we can be more precise with our therapeutic choices and we'll interact specifically with that mutation that's causing that abnormal protein and try and turn off the whole process and the cascade, which is why it's also critically important. So thank you for covering that, Pranav. Now, let's talk about, we've got a bit of tissue in front of us. You're examining it. You've done a H&E. Okay, you're going to move on to immunohistochemistry. What is immunohistochemistry? Tell us what that really means. What are we doing?
Okay, so there are multiple ways. So we know the cells have got antigens on the surface, right? So basically, immunohistochemistry is kind of an immunological test where you use the phenomena where you have an antigen on the, it could be on the surface of the cell, it could be within the cytoplasm of a cell, or it could be on the nucleus of a cell. So you use these antibodies, which are commercially available, which will go and we know through our basic immunology that the antigens and antibody bind to each other, right? So those antibodies, you put them on the slide, they'll go and bind to the cells if they have got the antigen. So when the antigen is present, they'll go and bind to the cell. So that's the basic underlying mechanism. Now there are multiple ways that you can identify that. You can use, when you say immunohistochemistry, so there's a chemical reaction that will happen. So you use a chromogen. Okay, so chromogen means something which produces color. Okay, so chromo means color and gen means generation, so generation of a color. So you use that mechanism. So when that reaction happens, then a color is generated, which in most cases will be a brown color. So when we perform immunohistochemistry, we see a cell staining brown, then we call it positive for that particular stain.
Right.
Now, the same mechanism can also be used during multiple ways. For example, you can use immunofluorescence, where you put fluorescent light and then it lights up. Okay?
Right.
So you can use the fluorescent marker, which is not so much used in oncology, but more commonly used in other facets like medical kidney diseases, where you use immunofluorescence to look for various antigens. There's another methodology which is used in hematology for blood cancers, which is called as a flow cytometry. Again, that uses the same mechanism where you have an antigen-antibody reaction. But then coming back to immunohistochemistry, so you have these markers that you use, which will go and bind to the cell if it produces a color, and which is what we look under the microscope, then you know this is positive for that antigen. So it's basically an antigen detection.
So when we think about looking, for example, in Lynch syndrome, where you've got these abnormal tumour suppressor genes, and you're really looking to see if they're not, if the whatever the tumour suppressor gene we're talking about is not there, you're saying, okay, well, it's mismatch repair deficient or mismatch repair proficient. If it's proficient, then that's fine. You've got a normal gene. If it's not there, then you've got an abnormal gene. That we're talking about something inside the DNA there, are we? Not on the surface of the cell. How is that working? There must be, there seems to me to be, there must be a lot of this around for you to be able to detect.
Yeah. So again, it's kind of, it's a screening mechanism. You're not definitely looking for the DNA, you're looking for the protein, right?
Yes.
So when you're looking at the immunohistochemistry, those proteins are being produced and you're trying to look for that protein.
It's the proteins you're looking for. Yeah, right, okay.
Yeah. So, and then when the protein is missing, and then you're trying to find a cause for why that is negative or it's missing.
Right.
Okay. And then you go back and look at the DNA to see what the cause is. For example, in case of when we test, and all the colon cancers anywhere in Australia would be tested by this. So it's a reflex testing now.
Yes.
So whenever we have a test, a biopsy or a bowel excision, all these tumors are tested for, as you said, MLH1, MSH2, MSH6, and PMS2. And if they're proficient, so proficient means normal, they're positive. But if they're missing, and then usually those patients, for example, like if it's MLH1 is missing, then we know a lot of the sporadic cancers can have loss of MLH1, and that cause is not Lynch syndrome. In those cases, it's a MLH1 promoter hypermethylation, and a surrogate marker for that is BRAF. So if BRAF is positive, then it kind of there's no direct link, but that has been found that if BRAF is positive, then it's a sporadic cancer.
Yes.
So in that case, you just leave it there. But if BRAF is negative, and then you refer the patient to a familial cancer clinic where they'll perform a germline testing. So for the audience, I think it's important to understand what is a somatic testing and a germline testing. So germline means any variant which is present in all our cells, so that you have inherited from your parents.
Yes.
Okay, so it is present in all cells of the body. So if you test your blood sample, you take a cheek swab, you take a hair follicle, all those cells will have. So even your normal body cells will have that variation.
Yes.
Whereas the somatic ones are acquired throughout your lifetime, so they'll usually only be present in your tumor. So when you test the tumor, you'll have that variation. If you test, and if we're talking about a solid tumors, if you test your blood sample or you take a biopsy of a skin, normal skin, then they should not be there. So in those cases, if there's a loss of any mismatch repair protein, the patient will undergo, and it's very important to have that pathway in the system where they go to a familial cancer clinic where you have the genetic counselors who are very, very well aware of all the facets of the testing, so they can, because it's very, very important for the patients to understand the implications, because the implications can go across generations. It can have implications on other members of the family, so it's important that they're properly counseled before this testing is undertaken.
Yes, I think, well, that's very well explained. I think that's extremely important. I just wanted to ask you about that immunohistochemistry. So I'm talking a bit about colon because it's one of my interests, but when we are looking at whether it's mismatch repair proficient or deficient, we're looking for proteins. Those proteins are inside the cell. We're not looking at anything that's now on the membrane. Am I correct in understanding there? In this instance, you're looking at what's inside the cell. The cell's been effectively, it's ruptured or spewed open on a microscopic level, and we're looking for it there. And then, as you mentioned, if you've got the MLH1 deficient, but you have this BRAF mutation, we can say, yes, but this is actually a somatic mutation, because we know that that's not going to be the case in pure Lynch. That's very helpful. So useful to know this. If we talk about, say, different organs, I'm not sure if you deal with breast tissue. What sort of things would we see in breast tissue? I'm just thinking about common things: breast, say, bowel, lung, prostate. We've talked about the bowel. Breast, is there something there that we're going to be looking for? We're often looking for hormone receptors, aren't we, in terms of, again,
that's right,
hormone choices. So anything else that we would want to know as primary care physicians?
Not routinely at this stage, but I think there are targets coming for breast cancer as well. And you, I think you briefly talked about BRCA mutations.
Yes.
And you can have this hereditary breast and ovarian cancer syndromes where they have a mutation, germline mutation in BRCA genes. So, but that's not routinely tested. But then there are these therapies which are now coming for the patients who have BRCA mutations. So these are called as PARP inhibitors. So they can be given to this patient. So ovarian cancer patients, like in our setting at Monash, all the ovarian cancer patients are tested, like high stage ovarian cancer patients are tested, where we undertake the quite comprehensive genomic profiling that includes not just BRCA1, BRCA2, but other homologous recombinant pathways. And there's something which has only come up in the last couple of years is homologous recombinant deficiency, which is another repair pathway mechanism. So we test for homologous recombinant deficiency. And if that is positive, then the patients are treated with these PARP inhibitors.
Right. Okay. That's, again, another advance, isn't it, that we have to look out for.
Mm-hmm.
In regard to prostate, BRCA1 and BRCA2 particularly can be associated with prostate. What are there any particular other things that are done with prostate or that we might see in a report that comes across our desk? Perhaps.
So again, as you said, BRCA1, BRCA2 is what is routinely tested, but a lot of them are now being tested again for the HRR genes like ATM, PAL-B2. All these, the PARP inhibitors again seem to be kind of helpful in those cancers. And other things, I think there are some fusion transcripts that are, but those are mostly diagnostic significance in case of a very poorly differentiated prostate cancer. When based on immunohistochemistry, sometimes the cancer is at a very high stage, then it doesn't differentiate that well. So differentiation means they don't mature well to produce those antigens on the surface that we're able to detect. So then you try to go at a DNA level and try to identify what cancer is it.
Yes, I think that's, there's so many tumours that we could talk about, but that's very helpful to have crossed over, looked at those three. I guess my other question is that, I mean, are there other things that you think that I haven't asked you because it's such a broad topic, something else that you feel...
yeah, we can go on any system and talk for so you can talk about gliomas where genomic testing has become so important, especially for diagnosis. The recent WHO classification of brain tumors. Talk about various genomic markers that are used for classifying brain tumors. So the brain tumors, most of which the most common ones are gliomas, and in the WHO system they are categorized from 1 to 4. So 1 being the lowest grade and 4 being the highest grade. And there was traditionally there have been histological kind of signs to categorize the tumor as a high grade tumor. But now with a lot of genomic findings, even in the absence of those morphological findings, you can create a tumor as a high-grade tumor. So there are mutations that you can pick up, and for example, there's a TERT promoter mutation. If you pick that up, then it automatically upgrades the tumor to a high-grade tumor, and then they're managed accordingly.
It's the way our whole medical profession is moving, isn't it? Better understanding of the molecular biology, which you're bringing to us. Where do you see the future of this, Pranav? Where do you think it's all? Can you see we're just going to keep on expanding our knowledge? Where do you think the future's taking us here?
No, I think that's we're moving very, very fast. And especially being in pathology, it's a challenge for us because you develop a test, and then in a couple of years' time, there are new expectations, new genomic markers that are required. So you have to kind of upgrade your panel in a way. So, but I think that's happening at a very, very rapid pace now, and I see that happening even faster in future, where a lot of patients will get, as you mentioned previously, precision therapy. So they'll get therapy based on what is the biology of the tumor, what kind of mutations or changes are there present in the tumor, and they get treatment based on that. So it's going to be a very, very personalized oncology or personalized medicine, as we say. So I think we are headed in that way. But again, as sometimes people are kind of ready to say that the traditional methodologies would become obsolete, but I don't see that happening. For example, immunohistochemistry, because when you look at a particular drug, what is it targeting? There might be a change which is present at the level of the DNA. right? But when a drug is going to go and bind, it's going to go and bind to the protein, okay? And when we are looking at the immunohistochemistry, we are looking at a protein level thing. So a lot of tests, and we know that a lot of trials, they use immunohistochemistry. They trust immunohistochemistry sometimes more than what they would trust a DNA-based test, right? So I think all these technologies would come together, and as a pathologist, we always have this joke going around that the tissue that we get is becoming less and less, and the expectations are becoming more and more. For example, and the expectation is that so 40 years ago, a pathologist would be expected to just make a diagnosis, right?
Yes.
So it's an X cancer, for example, it's a lung cancer. You're expected to call it based on morphology, whether it's an adenocarcinoma or a squamous cell carcinoma. But now we are expected to do all these ancillary molecular tests, which can be done on immunohistochemistry. For example, let's take an example of lung, where we are expected to do AL cross PD-L1, and then they expect us to do molecular testing on that. And that's where a lot of times challenge occurs, because the tissue is limited and there's only so much you can do. And similarly, in colon cancers, you have to do all this, apart from morphology, sometimes morphological diagnosis is difficult, so you have to perform stains to even reach to a definitive diagnosis. But then you have to do mismatch repair protein testing. You have to add on a BRAF. Then you might, in a metastatic setting, you might have to perform gene sequencing in cases of colon cancers. So so that's the challenge. But I think if you look at the patient side, I think with time, patients are getting more refined treatments, more personalized treatments.
Yes.
So.
Yeah, it's a very big field. And as you say, your expectations upon you are much, much more intense and higher than they used to be. Maybe not everybody, because the expectation for an outcome is, it's changed. The world has changed. How do you think AI is going to influence your job in pathology? Can you see, influences there, or how it might help you with your task?
Yeah, absolutely. And then I think with digital pathology, where we used to look at slides with a microscope, now those slides are being scanned, so you can look at it on the computer. So you can be working remotely and looking at those slides remotely, and then that's where AI comes into being. I've not don't have a first-hand experience of using it, but I know it's being used in some cases, like in prostate cancer cases. So I think it's gonna be a helpful tool for pathologists, where they're gonna be using AI technologies to make a better diagnosis. So for example, you could use an AI tool to screen the cases, and then you can focus on the areas of interest. So I think it's going to be a tool that pathologists are going to use in future more and more.
Yes, I think we're going to see that in clinical medicine as well, perhaps influencing goal choices. And, it may be a necessity for us to engage with it.
Yeah, no, absolutely. And I give an analogy of an airplane. 40 years ago, the planes were actually physically driven by the pilots, right?
Yes.
But most of the planes are pretty much automatic now. So they are kind of, it's not really AI, but kind of an AI where it's on an autopilot mode, but then you still need pilots to control them, right? So
yes, and to step in just in case and interpret things.
Absolutely.
Pranav, this is a little bit off pathology, but your advice for a young doctor, best advice, you can just give me your sense of, if you wanted to give some young doctor coming up to, please, doctor, give me some advice about medicine. What should I do, or how should I live my life within the confines of the constraints of being a doctor? What would you tell them?
No, I would tell them that have a feel of everything. So if suppose you're a medical student or a young medical graduate, you should get a feel of everything, and you should choose a specialty which is your passion. Because if it's not choosing something which is your passion, then you're gonna struggle, because you're gonna do that for the rest of your life, day in, day out. So it should be something that excites you, and every morning when you wake up, you get excited that you're going to go into your work and find something exciting. You're going to help the patients get to a healthy way of life, so to say. So that's what I would say, that have a feel of everything as an intern or HMO, and that should be the ultimate goal, that you go into a specialty which you enjoy working in every day.
Well, Pranav, thank you. I know my friend John Rees describes you as being excited about molecular pathology. I could see this is an area that you're an expert in, and you're a great star to our services in the area. So we're most grateful. And thank you for tackling what is really quite a complicated subject. You've made that a lot easier for us to understand. And
No, I think
thank you for being part of this.
I don't feel like I'm an expert because we are all learning each day, and I sometimes, we are flummoxed by what comes across our table. Every day you find these challenging cases, and we're all learning every day because technology is changing so fast.
Yeah, Pranav, thank you so much for your engagement with us. I really, really do appreciate it. Yeah, take care.
Thank you so much. Thank you.
I'd like to thank you for joining me in this conversation with Pranav Dorwal. I found this subject fascinating, and although the science is complex and changing, I hope this has given you some insights into the way pathology reports are now provided to us in relation to tumour histopathology. Well, during the podcast series, we will be covering a wide range of topics across many specialty interests. Discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@geohealth.com.au.